going to focus on the alimentary tract. So we're not going to talk a whole lot about salivary glands. We do have exams that we can do, contrast exams that we can do for salivary glands. Don't do them very often. So we're going to push the biliary system into the next section. So really what we have in the digestive system are two things. We've got direct organs of digestion, we've got accessory organs. So we'll get into the biliary system, we're talking about accessory organs of digestion. So what we're going to focus on here is going to be the alimentary canal, and that goes from food intake to food passing. So if you look on page 179, you see the entire thing. You've got the lips all the way to the rectum and the anus being your alimentary tract. So if you look over on page 178, again, the thing with the fan that looks like a fan, that's really the divergent central ray. Those are your required projections. Sophomore year, Amy's probably going to get into some of these other things that we're not going to cover in this semester. So specialty views that we're not going to cover in this semester. So the main ones that we're going to cover are the ones that you would do in the upper GI, an esophagram, very minimum, things like that. So that's what we're going to be focusing on for this. So the alimentary canal, again, extends from the mouth to the anus, and the major components, you've got the mouth, obviously, you've got the pharynx, which is that shared passageway for the food and the air before it splits at the esophagus. The airway goes anterior, the esophagus goes posterior. If you ever see a CT image of the patient's neck, you can differentiate between the two because you have cartilage that holds your airway open as opposed to the esophagus just collapses. It's just muscular tube. And then you've got the stomach, you've got the small and large intestine. We're going to further divide the large intestine into sections as well. So colon versus large intestine. So we have two different means of digestion. We've got mechanical digestion, and the most obvious of those is going to be your chewing. You start breaking down the food whenever you start to chew, but you also have enzymes that get dumped into even the mouth that help you to break down the food. So you have what they refer to as salivary amylase. That's not on the test, but that starts the breaking down of food. If you chew something long enough that is not necessarily sweet, you might start to taste a sweet taste in your mouth, and that's the effect of that salivary amylase. And then you've got the peristalsis that pushes everything down into the stomach. You swallow and it pushes everything down into the stomach, and the stomach kind of churns a little bit to further break down the food, but it also adds more enzymes. And that's really where the enzymes get added, is you get the gastric juices, and then once it passes into the small intestine, you get the things like the bile and the pancreatic juices. So both mechanical and chemical. So again, we're going to skip a lot of that. So we're going to skip all the way down to slide 18. The teeth are, again, an organ of digestion, but they are accessory. So I think that might actually be on the test, but we're going to skip past all that, and we're going to go all the way down to, let's just come out of that, go all the way down to here. All right, so I need to check. All right, so I explain this a little bit. So PowerPoints, I've got the information on PowerPoints, and then I've got some notes on some of these. So the end of course evaluations, we actually do pay attention to those and try to tailor things to make them a little make our lecture a little I don't know. We use your inputs, what I'm trying to say, right? So one year I got that the PowerPoints just had too much stuff in them, right? So what I did was I broke down the PowerPoints into just absolute need to know information and added some notes, right? And then is like the very next year, is like PowerPoints don't have enough information on what was in information. So, I'm just gonna do what I do, right? And y'all can adjust PowerPoints any way you want to. I do need to check in Canvas and make sure that this particular PowerPoint's there so that you can see, all the notes as well. I'm not sure that these actually made it into it. So, the pharynx, we just talked about that as passage for both food and air. You've got three different portions of that. You got the nasopharynx, which is up high. You usually don't have any food in that, unless sometimes if you have like a little baby that swallows something, usually for an object like a coin, and then they cough. Sometimes we get, we find that coin stuck up in the nasopharynx. But oropharynx and laryngopharynx, and at the laryngopharynx, we get the separation between the airway and the esophagus. So larynx is just your voice box, just below the epiglottis, very short portion from C4 to C6. Not really going to do any pharyngeography. So the esophagus then is a long muscular tube, and it's what conveys liquids from the pharynx all the way down into the stomach. So it lies at the mid-sagittal plane, sort of. It does take a couple of deviations. If it's directly at the mid-sagittal plane, you got to think of other things that are at the mid-sagittal plane, right? You got your aortic arch, you got the heart, and then it plugs into the stomach on the left-hand side. So it has to make some sort of deviation to get to the stomach, right? So it's at the mid-sagittal plane, yeah, mostly, but it does have some contour to it. It's not just a straight tube that goes from the mouth to the stomach. And it also does deviate as it travels through the thoracic cavity. So it's posterior to the trachea from C6 to T10. The distal end of it is what we refer to as cardiac antrum. That's the lower portion, and whenever the patient has reflux, any kind of reflux, you eat something spicy and you get a little bit of reflux up into your esophagus, you get that burning feeling that we call heartburn. Exactly. So if that gets bad enough, then what we can get is inflammation that causes a stricture at the distal portion of the esophagus. And with that stricture, you have a harder and harder time passing fluids and food from the mouth to the stomach. And then what happens above that stricture is you get expansion. Okay? So that's a condition we refer to as Barrett's esophagus, and it's because of that reflux. And a Barrett's esophagus, could be treated with something that could limit that reflux, or limit the amount of gastric acid that is present in the stomach. But very common condition. So the appearance, when we get into imaging, is a patient drinks a barium, and what you see is a normal esophagus until it gets to the distal end, and it expands, and then immediately it goes real tight, right? So as what we refer to as the rat tail sign, for pretty obvious reasons. It's just a little bit of barium that flows to that distal portion into the stomach. So you may see that in either the reporting or in your textbook. So again, we've got chemical digestion in the stomach. It really begins in the mouth with salivary amylase, but it starts in earnest in the stomach. A little bit of mechanical digestion. And the stomach is also divided into different parts. So we've got the cardia, which is the very top, where we've got the plug-in of the esophagus into the stomach. And the fundus is actually a little bit above the cardia, and that's the very tip top of the stomach. So whenever you shoot a KUB or an upright chest x-ray on a patient, you see that bubble, right? That is in the fundus. So you got the fundus, the body is the bulk of it, and then the bottom portion of the stomach into the portion of the stomach that goes from the patient's left-hand side to the right-hand side is what we refer to as the pylorus. Okay, so I'm just going to talk about that. So we've got the pyloric antrum, pyloric canal, or the distal portions of the stomach. And we can have some pathologies there as well. So one pathology that we'll see is pyloric stenosis. It's usually a congenital condition. The baby is born with a normal narrowing of the pylorus. And what we get with that is the inability of the baby to pass the food, which is really milk or colostrum, from the stomach into the duodenum, because you got a stricture there. A little bit goes through, but not enough that what's left in the stomach doesn't sour. So you drink soured milk, and what's going to happen?
Comes back up.
You're going to see it again, right? So that's exactly what's going to happen with these babies. Is that they drink the stuff, and then it sours in their stomach and projectile vomit. There's another condition that we haven't talked about, and that's what we refer to as esophageal atresia. And atresia means that something's not complete, right? So what you may have is the first part of the esophagus that completely pinches off and it stops, and then the lower portion of the esophagus picks back up, okay? So there's no connection between the two. So in that case, you're also going to have a patient that's going to regurgitate. The difference here is that the baby takes in it's usually colostrum, the first thing to have, and it comes immediately back up, as opposed to the pyloric stenosis. It's going to sit down in the stomach, it's going to sour, and then there's going to be that projectile vomiting. There's a third condition that's very similar to the pyloric stenosis, and that is what we refer to as duodenal atresia. And Amy's going to cover that in pathology, but duodenal atresia is just like esophageal atresia. It's an incomplete duodenum. So what happens is, again, very much like the pyloric stenosis, the milk gets down into the stomach, and then the patient projectile vomits. So you have a pediatric patient. It's important to get a history on the patient. What's going on with the patient? What specifically is happening with this patient, so that you can pass that on to the radiologist. Maybe a malabsorption syndrome. Baby looks emaciated, or it may be projectile vomiting. So you need to get that and pass it on to the patient or to the radiologist. So also on the body, on the medial side of the body, what we have is what we refer to as a lesser curvature. And lesser and greater in this case refers to the length of it. All right, so the stomach is J-shaped organ. So on the medial side, on the more towards midline, that curvature is going to be shorter, so that's going to be your lesser curvature. Lateral side is going to be longer, so it's going to be your greater curvature. Okay, so we can have ulcers on either one of those. With lesser curvature, it's more common site for ulcers, and also more common site for ulcers that are suspicious for future cancer, stomach cancer. All right, so in the stomach itself, both the entrance and the exit are controlled by sphincters. So you've got the cardiac orifice that allows the food into the stomach, and then you've got the pyloric sphincter that allows it back out of the stomach. That's what the stomach looks like. This would be, the patient's left-hand side over here. And we got the fundus above the cardiac notch. We got the body, lesser curvature because it's shorter as opposed to the greater curvature. And then the pyloric portion is that very distal inferior portion, pyloric sphincter. And then the duodenum is the first part of the small intestine, and it's also the shortest portion of the small intestine. So the position of the stomach is going to be affected by body habitus. If you have a patient who's hypersthenic, what you tend to have is a stomach that's very high and transverse, as opposed to an asthenic patient. You'll find the patient's stomach, the lower portion of the stomach, all the way down in the pelvic cavity. So it's very vertical, very J-shaped, as opposed to hypersthenic. It's going to be very high and transverse. It doesn't really look all that J-shaped. So that's going to affect your positioning. Right? We've got some specific projections for different body habiti. If you have a hypersthenic patient, we may add a view. If we have an asthenic patient, we may have to position way wide and way low. So function of the stomach, storage, secretes acid, starts that true chemical breakdown, got a little bit of mechanical digestion, and what we call the food as it leaves the stomach is chyme. The small intestine is all about digestion and absorption of food. So it's typically 22 feet long. Again, the duodenum is going to be the shortest portion, the jejunum, and then the ileum is the terminal portion. And notice the spelling of ileum. You got two ileums, or ilia. You got the bones, and then you've got the small intestine spelled with an E as opposed to the I. I don't know why I had the hardest time keeping those two straight, I don't know why they would do such a thing as this either, Of all the combination of letters, we had to do that, I don't know. All right, so the duodenum, very short, is the first portion, duodenal bulb. Then we've got a very large curvature. It's a C-shaped curvature supported by the ligament of Treats, and we have openings in it for where the bile and pancreatic juices come out. So in the next section, when we get into biliary, not really urinary, but biliary system, we're going to talk about that opening and how it is that we can image potential gallstones through that opening. So a very common exam type that we do is what we refer to as an ERCP. That stands for it's not on this test, endoscopic retrograde cholangiopancreatography. And it's an exam that we're looking for, gallstones. So that's in the small intestine. So a lot of stuff in the duodenum. So a lot of stuff going on just in that short portion of the duodenum. Also, common site for ulcers, and on a upper GI, you should see the first portion of first portion. I keep saying portion of the small intestine, and it looks like a good C-shaped appearance on the image. And what we see, though, is that if the patient has a pancreatic tumor, what will happen is that C-shape will enlarge because of the growth of the tumor. Okay, so that's something that's, I won't say commonly caught on a upper GI, but it is something that can be seen on upper GI. So small intestine just looks like a big wad of goo, right? So when we do exams of the small intestine, it's kind of difficult to determine which portion of the small intestine we're looking at. Right after we have the patient drink, you'll probably see the duodenum is very high. It's going to be way up here, right? So there's your duodenum. And then it gets into the rest of it, and it's like, I have no idea what I'm looking at. But what we're looking for is on that small intestine exam, and we'll talk about this here in a bit, is where the small intestine and the large intestine meet. What you're going to see in the small intestine, at least in the first portion of it, before all that contrast gets all the way down into the distal jejunum and into the ileum, is you should see the contour of the small intestine, and what the inside looks like is it's kind of fuzzy looking, all right? So the inside of the small intestine, you've got all these little things that control the absorption of the food. They're called villi, and they're like individual little hairs on the inside. Again, distally in the small intestine, you can't really make that out all that well, so it becomes more smooth. But once it gets into the large intestine is going to have a completely different appearance to it. And that is your telltale sign that you've made it to the junction between the small intestine and the large intestine. That's what we refer to as the ileocecal valve. It's where the ileum, distal portion of the small intestine, meets the colon, ileocecal valve. Okay? So when you're doing a small bowel series, that's what we want to see is we want to see spillage over into the large intestine, and possibly fluoro and get some spot images of that ileocecal valve, if at all possible. So the villi look like that. Again, the duodenum, ligament of Treats, pancreas, the head of the pancreas, that's right in that that C of the duodenum. So large intestine, the purpose for large intestine is, elimination of waste, but also absorption of water. So to maintain homeostasis, to make sure that you stay hydrated, that's one of the big jobs of the colon. So it frames the abdominal cavity, kind of, sort of. It goes up one side, across, and down the opposite side. And it's divided into the cecum, the colon proper, and then we've got the rectum and the anus. It's approximately 5 feet long. The haustra is that characteristic appearance of the large intestine. And what we have is a band of muscle that travels the length of the colon. That's what of the large intestine. That's what we refer to as the tinea coli. And what it does is it kind of bunches the colon up, large intestine up into these pouches. Okay, so the characteristic look of the colon, the large intestine, is that it's going to have these big pouches as opposed to that feathery appearance of the small intestine. So the cecum is the first portion of the colon, or the first portion of the large intestine. It's where the ileocecal valve lies, and its cytopathology specifically was hanging off of the bottom of the cecum is going to be your appendix. You'll see it referred to as the vermiform appendix. Most people just refer to it as the appendix, but in literature you may see it referred to as the vermiform appendix. I don't know why. But if it gets inflamed, it's just a lymph organ, and if it gets inflamed, then it can become what we call hot appendix. And a hot appendix may rupture, and then the patient's got a problem, right? So appendicitis is what we're talking about there, and appendicitis can theoretically be diagnosed with some sort of colonic exam, like a gastrograph enema. I used to work in a hospital that it was routine. If a patient came in with suspected appendicitis, we would do a gastrographing exam. Now, why would we do gastrographing? What is gastrographing? It's iodinated, right? So why would we want to do gastrographing as opposed to barium?
If it gets out of the body, it won't harden.
Exactly. It can be reabsorbed by the body. If it gets, if the patient's going to surgery, there's probably going to be some spillage if they go to remove the appendix that's, inflamed. So, there is a possibility you'll go to work somewhere where they'll do gastrographing enemas for suspected appendicitis. If the appendix is inflamed, then you may see it much larger than what it should be. If it's not inflamed, then barium or the gastrographing gets down inside of it, it just, I won't say it's a pencil fine line, but it's no larger than a pencil, if that makes sense. Not a pencil marking, but the pencil itself. All right, so then we've got the four portions of colon. We've got the right colic, the hepatic flexure. Synonymous, mean the same thing. Right colic, colon, colic. Or if you happen to be a parent and your kid gets gassy, what do we call that? Colic, exactly. Or if you're a horse person, colicky horse is not a good thing, right? So right colic flexure is the portion of the colon where the colon comes up and it makes a turn and it goes across the patient's body. And we'll look at that next week a little bit more in depth, but it turns, it goes across the patient's body, and it's right up under the liver, right colic flexure. If you have a right colic flexure, then naturally you're going to have a left colic flexure, exactly. And then the portion that goes in between them theoretically would be a horizontal line going across the patient's body, and that would be your transverse colon. And then, so you have ascending colon, right colic flexure, left colic flexure, transverse colon connecting them. Then you have descending colon. Then you've got, because, your rectum and anus isn't coming through your hip, right? It's got to go back towards midline. So you've got what we refer to as a sigmoid colon to get to the rectum and the anus at midline. So it looks like that. Ileocecal valve, ascending, hepatic flexure, transverse colon, splenic flexure, descending colon, sigmoid colon, rectum and anus. A couple of things about the colon, and we'll kind of review this before we get into the lecture next week, is the transverse colon is not always transverse. Kind of weird, right? We still call it transverse colon, but the orientation of your colon can vary wildly between patients. So your right colic flexor may be way down here, right? And your left colic flexor may be way up here, so your transverse colon's kind of going in a ascending oblique projection. Okay, it's still called the right colic flexor and left colic flexor transverse colon. But just know that in some patients, it just doesn't go straight across the patient's body. Tinea cola is that stripe you see on the top and the bottom, and that's what gives us our haustral markings, kind of bunches it up, the colon up, and gives us those haustral markings. We do have pathologies that kind of remove that characteristic appearance, and we'll talk about those as well. So reabsorption of food and elimination of waste products, and now we're going to skip again some of this, because now we're getting into the biliary system. All right. So we've got a number of different upper GI studies. And the first one we're going to talk about is modified barium swallow. So modified barium swallow, and we're not going to spend just a tremendous amount of time on this, because your part in this is really kind of set up and the just assistance. But it is worth discussing. So a modified barium swallow is usually involves a patient who has had a stroke or some sort of head injury, or for whatever reason they've lost their ability to swallow well. And what we're trying to do is we're trying to figure out what consistency of food the patient can eat or drink that they can drink without choking on it. So what we want to avoid is aspiration. Foreign bodies get down inside of the lungs, then it can cause a pneumonia, and the patient can have a bad outcome. If you've already got a patient who's just had a stroke and they're trying to rehab from the stroke, and now they've got aspiration pneumonia, it complicates things and makes their outcome less likely to be good. So modified barium swallow, what we're looking for is how to feed the patient, right? So in this exam, what we're going to have is you're going to be in the room, a radiologist or a PA is going to be in the room, and usually at least one speech pathologist will be there as well. And what you're going to do before you get the patient into the room is you're going to mix up some different contrasts. So you're going to have regular thin contrast, regular thick contrast, and then you may have to take some cornstarch or some sort of thickening agent to take the thick contrast and thicken it up even more. And if you look through your drawers in your fluoro room, what you should find is this thing that looks like kind of like a toothpaste tube. And it should say barium on it. It shouldn't be any guesswork, but it's paste barium. So what you're going to do is you're going to have at least all four of those. So you're going to have thick, or you're going to have thin, thick, thicker, and then you're going to have paste barium. You're also going to have something to put the barium onto, especially the paste barium, to get to the patient. So something like a cracker or marshmallow or something like that, you're going to have that available as well. So once we get all that set up, you go get the patient and you bring the patient in, and obviously they're going to be upright, but again, they're a stroke patient, right? So they can't really stand upright. They're going to be in a specialized chair that you're going to, and it's got to be fairly narrow. The fluoro table is going to be upright. The foot's going to be off of the fluoro table, and you're going to take this patient, you're going to move them into the space between the tabletop and the image intensifier, right? And then your job at that point is to give the patient whatever it is a speech pathologist says to give the patient. And so that's really the whole procedure. And the only thing that we're really looking for, again, is how well does the patient swallow? Do we have any kind of spillage into the airway, so that they can, make a specific meal plan for the patient. so that they're less likely to have those problems with aspiration. So that's about all that we're gonna talk about on that. I did post in the video on YouTube, I did post a couple of links. The first time I put this up, I guess one of those were copyrighted and YouTube jerked it. So I had to go back in and take those out and re-record a little bit of it and repost it, and I just put the links into the description below. So if you find that video, then you know you can see exactly what it is the setup looks like. Okay, you know, silly me, I thought, you know, I'm giving your video views, you know, and it doesn't work like that. So let's come to that. Most of the time it's going to be just straight just straight laterals, but you could do an AP or a PA. All right, so then let's get into esophagus, stomach, and all that. So we divide the gastrointestinal tract into upper GI and lower GI. The textbook, and especially the Bontrager's, started with the small intestine and the large intestine as being the lower GI. Tomato, you know, upper GI could be just the esophagus and the stomach. I always consider the small intestine part of the upper GI, overall upper GI. So the things that we need to consider whenever we're getting ready to do an upper GI series, or any kind of GI series, but especially upper GI series, is gastrointestinal transit. That means how long does it take for the stuff to move through the gastrointestinal system? What kind of exam are we doing, and you know, how long is it going to take? The first contrast exam you're probably going to learn to do is going to be an upper GI, because it's just KUB after KUB after KUB. If you happen to be working somewhere that they understand there's been a switch to go back to urinary studies like IVPs as opposed to CTs, and if you happen to be working in one of those type of facilities, then that may be your first, because it's primarily KUBs as well. But GI transit, how long is it going to take? What can you do to help that along? How long is the patient going to be there? Those sort of things. What type of procedure we're going to use? Contrast media. Contrast media is going to vary by a couple of different things. That is exam type and pathology. So again, if the patient is suspected of having to go to surgery, we don't want to put barium into the patient. We want to put iodinated contrast. But also, if we're looking for air contrast, you need to file this away and hang on to it all the way through the registry. If you're looking for air contrast, you have to use barium. So what we get with air contrast is a better image of the mucosal lining. Should have brought some of the barium from down at the lab. All right, so barium is very hard to penetrate. Right, very, very hard to penetrate. So where we have just solid barium, you can't see pathology on the back side or the front side of the anatomy. So what we do with air contrast is we not only put barium into the patient, but we also put some air into the patient so that we get a coating of barium, but we can see through that organ system. And that's what air contrast is. That doesn't work with iodinated contrast. It's always going to be barium. So if the patient's suspected of having a pathology like a diverticula, diverticulitis, inflammation of an outpouching in the colon or in the small intestine, then we're going to use air contrast, and it's going to be with barium. So it varies by pathology what's going on with the patient. All right, so preparation of the examination room. What you want to have is, predict what may happen with the patient. Anybody tasted any of the contrast? Yeah? How is it?
It's not good.
Not good? No? Anybody say it's good? What'd you taste? Is it barium or gastrographin? Was it white, or was it kinda look more like a, I don't know, Mountain Dew? This is white stuff?
Just the white stuff.
That's the good stuff.
Ew.
Yeah, yeah. So when I was clinical instructor over at ETMC, when I first came to work at TJC, every class I would have the students taste the barium. And then taste the gastrographin, providing they weren't allergic to iodine. You know, it matters, you know, where injectables, allergies to iodine may not matter with the iodinated drinkable contrast, it can matter. Okay, so make sure you get a good patient history on and find out if they're allergic to iodine before you give them iodinated contrast. But you know, I'd have them taste both, and the barium, it tastes like chalk, pretty much flavored chalk, but it's tolerable. You know, you don't want to drink much of it, but it's tolerable. The iodinated contrast tastes metallic, and they flavored it to kind of have a lemon lime flavor, but really what it tastes like is the bottom of a trash can. It's just awful. It is horrible. So you want to take patient history, you want to make sure that you have plenty of both of those available to you. And what you may see, different exam types, you're going to have different contrast. So if you're doing esophagram, that GI transit's going to be very short. If that's the only thing that you're doing is esophagram, it's going to be very short. And you want the esophagus as full as possible. You want thick barium. If you're doing a esophagram with an upper GI, it's going to take a while for the contrast to get out of the stomach. You still want thick barium. If you're doing a small bowel series in conjunction with those other two, eventually you want it to get to the ileocecal valve. So after you do your esophagram and your upper GI, you're going to switch to thin barium to try to help it to get through a lot quicker. So you want a variety of different contrast types. But regardless of you know, the type of contrast you're using, you want all this other stuff as well. All right? Because depending on the patient's, you know, pathology or their history or whatever, they may have a history of throwing up, right? So if you're standing in a room with a patient, you just gave them contrast to drink, and it doesn't sit on their stomach, and you're standing right in front of them, what's going to happen? They're going to puke on you, right? So what you want is plenty of towels to clean up, if at all, you know, if necessary. You want wash rags so the patient can wipe their mouth. Again, the barium's very chalky and it's white, so you know, if they drink it, then they're going to want to wipe their mouth, right? So make sure you have all of that, and we want to make sure we have some water on board too. If we're doing an upper GI or esophagram, what we might be doing that for is reflux. And I'll talk about how the water plays into that here in a minute. So exposure time, we want rapid exposure, because everything is moving, you know, with peristalsis pushing barium from the mouth into the stomach. We've got motion, so we want high KVP to try to penetrate some of that barium, but we also want the exposure time to be very low. So if we're doing a barium study, your minimum KVP is going to be like 110 KVP. Okay, that's for your fluoro, and if you do overhead images, then you also want that high KVP. And radiation protection, for the most part, is going to be that high KVP, and it's also going to be collimation. Make sure that you collimate. And the pathologies, you know, of course, you've got the pathologies in the textbook, but we're going to talk about some of those specifically. Again, peristalsis, 3 to 4 waves per minute. We talked about that. All right, so one thing that you'll find with the iodinated contrast is it has a little bit of a laxative effect to it. I've seen techs that would take a little bit of gastrographin, you know, if they had a partially used bottle, you know, a partial bottle, and they would empty some of that into the barium mixture, just a little bit, not enough to dilute it, just to have that laxative effect on the barium, so to get through the patient's small intestine to the, you know, to the colon quicker. I'm not saying I recommend you do that. I'm just saying that don't be surprised if you work with a tech that does that every now and then. You know, it's still dilution of the barium, could potentially give you a worse study, but I've never seen anybody put so much in there that it truly affected it. I'm not sure that it truly affected transit either, so, I don't know that it works. So, the iodinated contrast moves through a whole lot faster because of that laxative effect than what barium does, and it cannot be used for air contrast. We already talked about that. Reasons to use air contrast or iodinated. All right, preparation of the room. High KVP, we talked about that. If we're looking for air contrast, you may back off your KVP, maybe 100 KVP. Iodinated contrast, probably 590. If you are doing an exam that starts with the patient upright, put the footboard on the table and then test it. All right. So the way the footboard loads onto the table are the little tabs. You got to slide it in from the bottom, and there's little tabs that have to fall into place. And sometimes they kind of fall into place almost. It's kind of like, let's say you pull your door to your house almost shut, but it's not completely shut. It doesn't click into place, and then the air conditioner kicks on and it pushes your door open. Anybody ever experienced something like that? Okay, well, kind of similarly, if those tabs don't completely engage, and then you take the patient, you stand the table up, if it doesn't slide off, the footboard doesn't slide off when you stand the table up, what do you think is going to happen whenever the patient steps on it?
Going down.
It's coming off. It's coming off, right? And these are not healthy patients. If they were healthy patients, we wouldn't be doing GI studies, right? Their other foot may be under it, so you may drop all that weight on the patient's opposite foot, harm the patient, break a hip. You got all kinds of problems there. So the point to this is you slide that on, and then you grab it, and you try to tear it off of the table, okay? And if you can't pull it off of the table with a good, hard jerk back and forth, it's there, right? And it's going to be fine. And then you stand the table up and get ready for the patient. So your number of IRs available, that will be in a CR type room. Make sure you have proper contrast. We've been through all that. Make sure you have your appropriate markers, not just your markers, but some hospitals want you to put specific markers for the exam type. Like, for example, if you're doing an upper GI small bowel series, they want differentiation between those images. So you may put, an ESO's marker on esophagram, UGI on upper GI, and then your small bowel follow through are going to be timed. So it's going to be like 15 minutes, 30 minutes, 1 hour, things like that. So make sure that you've got all those available. Again, have some water available. The CO2 packets, everybody seen an upper GI at this point? Anybody not? Not to put anybody on the spot, it's not your fault if you haven't seen one, we just don't do as many. Okay, well, the CO2 packets are what a lot of the texts will refer to as the fizzies, introduce the air that provides the air contrast. Okay, so make sure you have some of those available as well. So towels, trash can liners, really recommend trash can liners over an emesis basin. We're going to take a break here in a minute, but an emesis basin isn't a whole lot larger than the head of this, right? So you fill the patient up, you give them, 2 pints of barium to drink, and it comes back up. That's not going to hold it, right? So what I really recommend that you do is make sure you've got a clean trash can liner, and then have the trash can immediately available so that you can scoot it over to the patient. You don't have to aim at a trash can, right? You give them one of those little kidney bean shaped emesis basins, and they've got to be pretty precise. Have all the stuff that we talked about before. So describe the contrast to the patient. Don't lie to them. Don't say it's really not all that bad. It's every bit that bad, right? Especially the iodinated contrast, just tell them it's pretty bad. One thing I can say is that whenever you order barium, you'll get with the barium straws that look like oxygen tubing that are a little bit bigger than this Sharpie. They're big, okay? And for whatever reason, every hospital I've ever worked in takes those things, they just throw them away. And then they give them those flexible bendy straws, which are great if the patient's laying on their stomach and sipping the barium while the patient's in the room. Get some of those and stick them in your locker. If you've got a patient who's got, you're gonna have to do an iodinated small bowel series, break one of those things out. You can bypass most of the taste buds by giving them one of those and just having them suck through that great big thick straw as opposed to those little bitty skinny straws, okay? Much, much easier to get the patient, to drink them out of those as opposed to the little bendy straws. So explain the exam, explain the procedure to the patient, introduce the patient to whoever's doing the fluoroscopy. Again, your motion artifact is a concern, so we'll want to use short exposure time. Okay. It's peristaltic activity. We'll talk about radiation protection. So why don't we take about 10 minutes and we'll come back and we'll talk about the esophagram.